So we're going to talk today about cutaneous manifestations of dermatomyositis. And to start, I want to review some of the cutaneous features. In previous Sondheimer criteria, pathognomonic features have been Gottrin's papules and Gottrin's sign, and we'll show you examples of this. And then characteristic features are heliotrope, periungual telangiectasias, dystrophic cuticles, and photodistributed violaceous erythema. There are a number of secondary skin features that can also be seen, including subepidermal vesicles and or blisters. And some of these can evolve into superficial erosions and ulcerations. And you can see a vasculopathy sometimes, particularly with certain autoantibody associations, and we will also talk about that. Poikiloderma can be seen, and that would be described as hyperpigmentation and hypopigmentation, telangiectasias, and superficial atrophy in the skin. And then lastly, cutaneous calcinosis. So this is showing you, if you look over the proximal interphalangeal joint, there's some papules there, and also over the MCP, you can see that there are papules that are red to violaceous in color, and they're definitely elevated again above the skin surface, not just flat erythema. And so that would be called a Gottrin's papule. Gottrin's sign is where you have erythema in that same distribution, so over the joints, and you don't see the papules as much, but you can see erythema. You can also have Gottrin's over elbows and knees, as you see here, and these are all areas of stretch where you can often see these features. Another element that we often see is heliotrope, and you can see here erythema and some dyspigmentation and scale on the upper eyelids of this patient with periorbital involvement with their dermatomyositis. Sometimes in darker skinned people you'll see more dyspigmentation, but if you look at the edge in the folds of the eye, lateral canthus, you can see that there's some scale there and also a little bit of erythema, and so you have to look in those areas, and also at the medial canthus you can see as well that there's some scale. And so these are the kinds of things, again, that you would look for. Sometimes there's a lot of itching and people will rub, and so this is showing you the kind of like lichenification with increased skin findings, markings that you can see along with the periorbital erythema in a heliotrope rash. This is showing you typical changes with periungual dilated blood vessels, and you can look for these either with the naked eye or with some kind of magnification like with the dermatoscope. And if you see these, then again, that's something that would be associated with dermatomyositis, although very similar features can be seen in scleroderma as well, so it has to be put in the clinical context. This shows through dermoscopy the kind of looping and dilation and dropout that you can see, as well as hemorrhage in the proximal nail fold. And then there's also cuticular dystrophy with overgrowth of the cuticles. This is showing you erythema, the proximal nail fold, as well as dystrophy of the cuticular dystrophy. Again, very good features that you see in dermatomyositis. There's a loss of nail fold capillary loops that has a strong association with skin disease activity. And again, the features being hemorrhage, irregularly enlarged capillaries, and loss of capillaries. So before treatment on the upper line, you can see the kinds of changes that are seen, and then after treatment, these actually do improve. And so this is something that can be followed in terms of improvement with therapy. There's a photodistributed erythema with erythema in the malar area involving the nasolabial folds, and also you can see here in the V of the neck. And these are very common areas to look for, and it's typically violaceous erythema is not unusual. This is looking at the area of the Shaw sign with the posterior neck and the upper back, and extending actually on the right up into the neck and into the scalp. And these are very common areas of photodistributed violaceous erythema and dermatomyositis. Here are the extensor arms extending onto the hand. Here the upper back, neck, and extending onto the lower back. You can see erythema and scale. Typically these are itchy. Here's the V of the neck, kinds of changes that you can see. Secondary features are subepidermal vesicles and blisters that can evolve into these erosions, and we talked about some of the other changes that can be seen. But here's a livido where you can see some breakdown in the skin, but this would not be considered a primary skin lesion. This is really due to the vasculopathy and leading to the kinds of livido that you can see often in dermatomyositis. Here's some poikiloderma, so hypo and hyperpigmentation. That's part of the damage from the disease, in addition to the erythema and scale that you can see as part of the activity. So this is showing you really elements of many aspects of the disease. Calcinosis can be either under the skin, as on the left, or exophytic on the right, and these are very characteristic also in dermatomyositis, although more common in pediatric or juvenile dermatomyositis. So I just want to review a typical case. These patients often have problems getting a diagnosis, and so this is a patient who had erythema on his skin for 10 years, was diagnosed as psoriasis for 10 years, had never had a skin biopsy, treated with all kinds of therapies for their psoriasis and did not get better. What you can appreciate here is that there are, the patient has changes on their dorsal of their hands with some scaling over the joints and erythema, and also scaling along the sides of the fingers, which is something called mechanics hands. Also a little bit of V of the neck dyspigmentation and maybe some pink erythema. There's some scaling on the ear with erythema. The heliotrope is there along with the malar rash, and also on, Gotrins on the knee with some crusting and erythema. So that patient had dermatomyositis and actually had a TIF1 gamma antibody, but again, something that would be very easy to miss without a biopsy and really putting the clinical path correlation together to make a diagnosis. This is looking at the role of autoantibodies, and there are certain phenotypes that we associate with specific antibodies. So there's an anti-MDA5, which is seen with interstitial lung disease, and rapidly progressive disease can be seen, particularly in Asia, but we see it in other ethnic groups as well. There's the anti-nuclear proteins, which include the anti-TIF1 gamma, which can be associated with malignancy, anti-NXP2, SAE, and anti-MI2. And there are certain types of clinical characteristics that we often associate with the presence of these particular antibodies. So in the anti-MDA5, about 13% of the patients in one cohort actually had MDA5 antibodies and had a higher incidence of lung disease, skin ulcers, as you can see on the right upper picture. Palmar papules can be seen, mechanics hands is on the right lower picture, as well as oral lesions and alopecia are more frequent in patients who have the anti-MDA5 antibody. Again, typical ulcers, often over the joints on the hands, often associated with arthritis, and here you can also see changes over the MCPs with scaling and a little bit of crusting. This is also showing the type of alopecia that can occur, and it can be quite extensive, and very rarely it can be even scarring alopecia. Mechanics hands is scaling along the sides of the finger and sometimes extending onto the palms. There can also be erosions in that area, and there's an increased association with ILD. This is looking at mechanics hands again and palmar papules on the right, which can be seen in association with MDA5, along with other types of antibodies seen in dermato as well. So anti-TIF1 gamma tends to occur with more extensive skin disease, and some of the features that have been associated with anti-TIF1 gamma antibody include palmar hyperkeratotic papules, psoriasis-like lesions, hypopigmented and red on white telangiectatic patches, less calcinosis, some increased malignancy relative to other autoantibodies, less ILD, less Raynaud's, less arthritis, arthralgias, and mild myositis. The anti-P155-140 antibody is also associated with poikiloderma, flagellate erythema, and bully formation. And these are all interesting characteristics to try to associate with the phenotype, but these findings can be seen with other autoantibodies as well. There's also seems to be a higher antibody level on ELISA correlating with the presence of cancer, and so that, along with maybe particular isotypes of the TIF1 gamma, may in the future be more prognostic of increased risk of cancer. Approximately 20% of patients with anti-TIF1 gamma will have an underlying malignancy. Other features of anti-TIF1 gamma are the psoriasiform change on the left, and then the hyperkeratotic papules with erythema over the joints on the hand on the right. Here's the red on white changes you can see on the left, and hyperkeratotic palmar papules. This is also red on white anti-TIF1 gamma patient, and again, rather distinctive appearance. NXP2 is a different antibody which is involved in the regulation of P53-induced cell senescence in response to oncogenic signals, and has been found in about 11% of one cohort. It's been associated with male gender, dysphagia, myalgias, peripheral edema, calcinosis, and less clinically amyopathic or milder skin, decreased Gottrin sign, and increased risk of malignancy. So the TIP1 gamma and NXP autoantibodies can be associated with malignancy, and it's important to think about screening really all older patients with dermatomyositis, but in particular the patients with those antibodies. The SAE is seen in a smaller percentage of adult dermatomyositis cohorts, 1.5 to 8%. Skin disease tends to happen first and then progressing to systemic disease, which can include muscle involvement and dysphagia. The anti-MI2 is seen in 20% of adult dermatomyositis patients and is associated with classic skin eruptions in a sun-exposed area. The things that we've already looked at previously are outlined there, and really typical findings for MI2. Myositis, mild to moderate, can be seen, tend to have less lung and joint involvement, and they tend to be steroid responsive, and when they respond, the disease can go into remission. It's worth remembering that there are some mimickers of dermatomyositis, including multicentric reticulohistiocytosis, where there's a variant which can be photodistributed and can really be a clinical ringer and look exactly like dermatomyositis. For those, that's one of the reasons why getting a biopsy to rule out other mimickers can be very important in patients where you're thinking about a diagnosis of dermatomyositis, looking for a lichenoid dermatitis. And what you see here is a multicentric reticulohistiocytosis and the presence of multinucleated giant cells, which is something we don't tend to see in patients with dermatomyositis. So the biopsy can be quite helpful to rule out things that are not dermato. This is also photodistributed MRH, and you can see there's on the right, even looking a little bit like Gotrin's and streaking along the extensor tendons. So clinically, you wouldn't necessarily know this is MRH. The classification of dermato is pretty extensive, and in general in the skin we're looking at patients who have either adult dermatomyositis that can be associated with malignancy, also juvenile dermatomyositis. They're patients who have dermato overlapping with other connective tissue diseases, and then they're patients who have amyopathic dermatomyositis and don't have any muscle involvement. And that's actually a group that has in the past been rather not well recognized. The reason for this has been that the criteria for dermatomyositis, the Bowen and Peters criteria, really required the presence of muscle disease, as outlined on this slide. And if you didn't have muscle disease, you couldn't even be determined as possible dermatomyositis. We now know that there are lots of patients who have just the skin findings, and that it is important not to miss the diagnosis of dermatomyositis in those patients because they do have an increased risk of interstitial lung disease as well as risk of malignancy. So to make a diagnosis of dermato, we often require a skin biopsy showing interface dermatitis. We do check for muscle enzymes, and if there are muscle symptoms or increased muscle enzymes, we will check EMG or MRI to document muscle involvement, as well as doing a muscle exam. A muscle biopsy is helpful for polymyositis, but if you have the skin findings of dermato and a biopsy in the skin that indicates dermato and the patient has muscle findings, you do not need to get a muscle biopsy if you can document with muscle enzymes and EMG or MRI. We do check myositis autoantibodies, but they are frequently in commercial labs right now negative, and so they're helpful if they're positive, but you can still have dermato and not have the presence of myositis autoantibodies. The diagnosis of amyopathic DM is a typical skin changes of dermatomyositis that we just spoke about, but a lack of muscle findings of any type. No matter how hard you look, you don't find muscle disease. Hypomyopathic dermatomyositis are patients who have the typical skin findings of dermatomyositis, and they may have some findings in terms of slightly increased muscle enzymes or even abnormalities on other testing of the muscle, but they're subclinical. The patient has no pain or weakness in the muscles, and it's all subclinical. And so we tend to combine the patients who have amyopathic dermato and hypomyopathic dermato in a designation called clinically amyopathic dermatomyositis, where the main complaint that the patient has is the skin. We know that the incidence of clinically amyopathic dermatomyositis is at least 20% or 21% based on this one study from the Rochester Epidemiology Database. However, it's likely that the percentages are even higher because of the underdiagnosis of patients with clinically amyopathic dermatomyositis. There are often problems in getting a diagnosis, as we saw with the other patient. They're often misdiagnosed with SLE, and the reason for that is that the criteria for SLE very much overlap with findings we see in dermatomyositis, including a malar rash, photosensitivity, ANA, and oral ulcers. So one of the things to look for in the malar rash is, again, involvement in the nasolabial fold area as opposed to just on the cheeks, which is more typical of lupus. The skin biopsy for lupus versus dermato is identical, and so you have to distinguish between those two findings based on the clinical presentation. The criteria for amyopathic DM have been redone, and we'll be talking more about this. And what we know is that, at least from our cohort of dermatomyositis patients, we found that only about 44% of them are diagnosed with dermatomyositis prior to referral. And the thought is that the referral patients have something wrong in terms of autoimmune disease, but it hasn't been characterized. And when we look at the 232 patients that we had in our database at the time that the study was done, we found that 37% of them had been called lupus when in fact they had dermato. 30% were undifferentiated connective tissue disease, 7.8 were undiagnosed, and then 25% were other, such as our patient with psoriasis that actually had dermatomyositis. There are now new criteria that Ingrid Lundberg in Sweden worked on with an international group of physicians and experts in this area, along with doing careful data analysis. And there are now 3 variables that have been included in the new ACR-EULAR classification criteria that are skin variables, and these include heliotrope, Gotrins papules, and Gotrins sign. We know that, and with these new criteria, if you have 2 out of 3 of these, then you can fit into the diagnosis of clinically amyopathic dermatomyositis, with encouragement that a skin biopsy be done to help confirm the fact that this is an autoimmune disease. We found that amyopathic DM is often presenting to dermatologists and other specialists, and it's really important to realize that in a rheumatologic population, these may not be diagnosed or may be not even presenting to rheumatologists. And so again, if you see a patient with skin predominant features that we've already looked at, you need to really think about the possibility of clinically amyopathic dermatomyositis. Our old criteria, including Bowen and Peter and many of the other ones listed here, really do not allow defining patients who have skin predominant disease. So in terms of the new criteria, we know that they really capture about 75% of the patients who have known dermatomyositis, but there's still room to go in refining criteria in the skin. We feel that we can probably capture a few more patients by refining the skin specific criteria. We do think that autoantibodies can be helpful in diagnosis and patient assessment and prediction of complications and prognosis, as well as potentially developing a therapeutic strategy. And we've really reviewed these antibodies, but again, I want to emphasize that there's also anti-synthetase antibodies that can be seen in association with mechanics hands, as well as other features of dermatomyositis. And these patients certainly have an increased risk of interstitial lung disease as well. And so to get a diagnosis of anti-synthetase syndrome, you have to have at least one of those antibodies and either lung disease, myositis, or polyarthritis, and also to have fever, Raynaud's, or mechanics hands, which you can have, but you don't have to have. We have found that mechanics hands are present more frequently in patients who have interstitial lung disease, but plenty of patients have mechanics hands and don't have ILD, so it's only really an association. But if you have a patient that you think has dermatomyositis, it is worthwhile to screen their lungs and get pulmonary function tests, including diffusion capacity, to rule out the possibility of interstitial lung disease. And we have found that mechanics hands can be seen in association with many other autoantibodies, including, as you can see here, anti-TIP1 gamma, and it's not a specific finding for anti-synthetase antibodies. So mechanics hands are seen in really every variant, including anti-synthetase syndrome, polymyositis, classic dermato, and clinically amyopathic dermato. And even biopsies have been done of mechanics hands and frequently show interface dermatitis. So in conclusion, dermatomyositis is frequently misdiagnosed. The pathognomonic findings of heliotrope, Gotrins sign, and papules are important and are now incorporated in the new EULAR ACR criteria, which will allow better diagnosis of these patients. Involvement of the nasolabial fold is helpful in differentiating from systemic lupus. A skin biopsy is important to rule out other diseases. And the new ACR-EULAR criteria are much better in identifying patients who have skin-predominant dermatomyositis. Thank you very much.
Thank Dr. Victoria Werth for an excellent lecture on the cutaneous manifestation. So any questions the speaker can be conveyed by the coordinator and the speaker will answer the question. It's a predominant dermatology crowd, yes. We do have few dermatology residents, I know. Actually, I think one thing from our side, what we can say is pruritus is another manifestation of dermatomyositis. So it can, the dermatomyositis can initially just actually manifest only as pruritus also. So that's one thing which many patients can be missed even in the skin OPD. That's one thing we can, the message we can take forward to.
So if there are no questions, I think we can thank the speaker and the audience for your attention and the organizers. Thank you very much.